So good afternoon, dear colleagues, and welcome to Athens. I'm going to talk about the learning curve of robotic prostatectomy. So what is the learning curve? Is that okay? So it's a period during which a surgeon finds a procedure more difficult, takes longer, there's a high rate of complications, and there's lower efficacy because of inexperience. It's a term that was taken from aircraft manufacturing and from pilot training, and nowadays it's implemented in surgery. And this is a nice paper from my friend Kamran, which has implemented learning curve in surgery, and we see that there are surgeon factors, patient factors, and team factors that influence the learning curve. Of course, it's really important, and that's why we're making a lecture about it, because it influences patient safety and surgical education. There are different types of learning curves, and every operation has a unique learning curve, and also every surgeon has his own learning curve. There are exponential kind of learning curves where we have a rapid increase of skill acquisition, after which a surgeon reaches a plateau, and then after that improvement is really slow. And we have the so-called steep learning curve on the right side, where it's a difficult initial learning process. So what are we really measuring when we are talking about the learning curve? So going through the literature, there are a lot of papers that talk about a surgeon being competent when the OR time is lower than, let's say, 4 hours, or as low as in open surgery, and so on. Other papers study the positive surgical margins, the biochemical recurrence, complications, continence, potency. So there are different factors that influence a learning curve. So there are different, I would say, learning curves for every factor that we measure. And also there are other papers that measure estimated blood loss, conversion rate, and length of hospital stay. So which learning curve we're talking about? And the topic gets even, I would say, more confusing when we're talking about which learning curve. So are we talking about an open, experienced surgeon that has done many open prostatectomies and is shifting to robotic surgery? And I would say most of the literature is concentrated on this part, since in the United States, laparoscopy didn't really launch in urology, and most of the surgeons were open surgeons and shifted to robotic surgery. But also back in Europe, we have really experienced laparoscopic surgeons that shifted to robotic surgery. So which learning curve are we talking about? These are completely different things. And also we have a young breed of surgeons, young surgeons such as myself, that have some experience in open surgery, some experience in laparoscopic surgery, and have shifted after a fellowship to robotic surgery. That's a different learning curve. And also, do other robotic operations influence the learning curve of robotic prostatectomy? For instance, we have an attendee or a consultant doing robotic nephrectomies, upper tract oncology, and has shifted to robotic prostatectomy. That's a different learning curve. And personally, I've seen that even non-robotic operations, such as reconstructive operations, influence also the way I've been dissecting and preserving and respecting, I would say, the neurovascular bundle. So a lot of things influencing the learning curve. So in robotic prostatectomy, as in any surgery, we have specific surgical steps where any surgeon, all surgeons, have to adhere to in order to complete the operation. Each surgical step has a how I'm going to do this surgical step, which tools to use, what traction I need from my assistant, what plane of dissection, if I'm out of this plane, how to correct this plane of dissection. And each surgical step has a skill set, specific skills that I need to acquire, to know, to master in order to do this step. So for me, there's a learning curve about those specific skill sets. For instance, the anastomosis is a specific step, And the skills for that specific step is suturing. So there's one learning curve for that, and there's another learning curve. Suturing in a pelvic trainer doesn't mean that I can do an anastomosis. Suturing an anastomosis in the pelvic trainer doesn't mean that I can do a prostatectomy. So as far as something simple as a pack transfer is concerned, it can be really daunting doing it laparoscopically. Whereas robotically, I challenge everybody of you, there's a robot out there in the exhibition, you can go right ahead and do it. Suturing, which is another skill set. This, in order to suture, you need first to place the needle on your needle holder in a perpendicular way, and then master the knotting technique, a double throw, a single throw, and so on. I think robotically, every single one of you, if you go to the exhibition and try to suture, I think more or less all of you will do a suture directly. So the skill sets is really, the learning curve for specific skill sets are really easy for robotic, in the robotic platform. But that doesn't mean that you can do a prostatectomy. Adding up all those skills doesn't mean that you can do the surgical steps of a prostatectomy. Even though you've been dissecting in a porcine model, it doesn't mean you know how to dissect the bundles on a human being. So this is a challenging part, and let's see the evidence on this. So in the United States, there was a diffusion of robotics in the whole country, even in community hospitals. So what is the learning curve recommendations for robotic urologic surgery? At its best, it's level of evidence 4. It's subjective, and non-validative metrics have been used. This is a review paper. And we see, in order to define competence, because that's the whole idea of the learning curve, to define competence of a surgeon, some have used operative time similar to laparoscopic OR time. Others have used a threshold of 4 hours. I don't know why 4, not 5, not 3. It's something they came up with. And something more recent is the positive surgical margins. So there's a huge heterogeneity of the learning curve metrics, and there are definitely different definitions of competence. So I think all of us remember these early papers back in 2002 from Mani Menon. I think also Vip Patil published on that. On 10, 20 cases were enough to do a robotic prostatectomy. As this matured more, we went up to 100, 200 cases, 400, and nowadays there are papers published with an unrealistic high learning curve, like 1,600 cases. So going back to European Journal of Urology, something more important for the patient is the positive surgical margin. So we have the learning curve of 100 consecutive robotic surgeries, and the authors have divided in the first 33 cases, the next 33 cases, and the last 34 cases. And these are the 3 groups. And as we can see, the positive surgical margins get much better as experience adds up. This is more emphasized in the PT2 patients and less in the PT3. That means that PT3 patients need even more experience, a longer learning curve in order to master prostatectomy for PT3 patients. And as far as the location is concerned, we can see that the bladder neck, they had 5 positive margins in the beginning, and that went down to 0. And at the apex, initially there were 8 positive margins, and that went to 3. What the authors conclude for this is that the bladder neck has a lower learning curve, an easier learning curve than the apex. Dissecting the apex is more difficult. So the learning curve doesn't only reflect the whole procedure, but also specific parts of the procedure. And to conclude, according to this paper, there's a steady reduction in positive surgical margins after 30 cases. A systemic review, again, from my friend Cameron, looking into the learning curve of robotic operations and other operations. Of course, comparing novice and experienced, the OR time, blood loss, and complications, and surgical margins went down, nothing new there. What is interesting is this table, actually there are two tables divided into two, where the learning curve, you see different numbers there. What the outcome measured, each study measured different outcomes and the previous experience. So what we see here, we see numbers all over the place. 250, between 80 and 120. This is more interesting. 40 cases for OR time, 10 cases to master the urethral anastomosis, 200 cases for positive surgical margins, and so on. And this is the rest of the table where you see, again, different numbers. So the learning curve, according to this review, which includes all other papers on robotic prostatectomy, the learning curve can be from 20 up to 1,600. So please don't ask me in the end what is the conclusion and which is exactly the learning curve. So anything, pick a number, depending on the study you want to follow. What about going back to that subgroup of experienced laparoscopic surgeons? So we have here 2 laparoscopic surgeons really experienced, more than 1,000 laparoscopic procedures, and I again quote, more than 1,000. That's a handful of surgeons in Europe. So they compared their last laparoscopic surgeons with their first robotic operation, and no wonder the PSA, positive surgical margins, potency, were exactly the same. So what do we understand? What we take as a message from this? If you have done more than 1,000 laparoscopic operations, probably you don't need a robot. And second, the learning curve for and really experienced more than 1,000, I quote again, the learning curve for a robotic operation is almost 0. Again, from a really highly really known surgeon from the Montsouris, again, compared their laparoscopic operations to their robotic ones, and the first robotic operations after already having done at least 250 laparoscopic operations, 9 surgeons. What they found is that the learning curve for laparoscopic robotic surgery is 350, whereas in robotic surgery is around 100. And we see the cutoff of laparoscopic and robotic surgery. So we have another study here, again, shifting back to an open surgeon that has more than 3,000. I don't know many people that have more than 3,000 open procedures. And this guy measured his first 1,500 cases robotically. And what we see is, in order to reach point zero means that his robotic operations, as far as sexual function is concerned, reached his standard of open procedures after 99 cases. So this really experienced open surgeon shifted to robotic, and after 99 cases he had equal sexual functions with what he had already in open surgery. But what is interesting is, if you follow up the learning curve with robotic surgery, you would expect that after 3,000 open operations, this cannot get better. With robotic platform, this got better and went way up 10%. So the learning curve is 99, and an open surgeon can get better with a robotic platform. The same goes also for urinary continence, 182 cases for the learning curve, but this surgeon again got better, even with this huge experience. The same for positive surgical margins, 108 learning curve for PT2, 223 for PT3 and PT4 patients. So nowadays what we need is more or less to have a structured modular training pathway and a way to monitor how the surgeons get better. So through a rigorous process, the authors reached a specific assessment tool dividing to the robotic prostatectomy to 17 stages and 41 steps, and each of the 15 robotic trainees were evaluated, and a learning curve was extrapolated, and they found that for the anterior bladder neck transection, one surgeon to be competent, he needed 16 cases, for the posterior bladder neck, 18 cases, posterior dissection, 9 cases, and for dissection and prostatic pedicles, 15 cases, and anastomosis 70 cases. What does this show is that there's a learning curve for each part of the operation. And there we should identify critical steps, and there's a specific experience needed for each step. And it's good to have an assessment tool and to monitor each step. So take-home message, learning curve is not easily defined. I think I showed that to you through that review. The numbers are all over the place. It depends on what is measured and the previous surgical experience. Any surgical experience, I think, counts. Fellowship training shortens the learning curve. Previous laparoscopic experience does shorten the learning curve. We need definitely validated assessment tools, and we need to monitor the results. And of course, as everything, and the same thing goes for pilots, and that's where we're learning how to train other surgeons, is we need a standardized training pathway.